I'm going to go ahead and get started. Although this is still early by my usual time clock. So hopefully folks will continue to join. And we're so thrilled to have so many of you here. I think 250 people have registered, which is fantastic. And I already see names and friends from far and wide, including from Twitter. Shout out to all the Twitter people out there. Thank you for joining us for our kickoff this year for our National Recovery Month keynote speaker event. Recovery Month, when we think about it, is really a month to me that's about hope and healing and love. And at the end of the day, nothing says more about love and caring for other people and humanity than harm reduction. And so I'm thrilled that our theme this month is on harm reduction, and that we have two of my sheroes talking with us today as our keynote speakers. The topic of today's talk is harm reduction, a pathway to autonomy, hope, and healing. And I'm honored to get to introduce our speakers. For those of you that I don't know, my name is Sarah Wakeman. I'm the medical director of the Mass General Hospital Substance Use Disorder Initiative and medical director for substance use disorders at Mass General Brigham. I will be introducing our two speakers, starting with Monique Tula. Monique Tula is the executive director of the Harm Reduction Coalition, a national advocacy and capacity building organization that promotes the health and dignity of people affected by drug use. Previously, she was the vice president of programs with AIDS United, where she oversaw the grant making and technical assistance portfolios. With more than 20 years of experience in the nonprofit sector, Ms. Tula has devoted her career to harm reduction advocacy and infrastructure and development of community-based organizations. Ms. Tula is a skilled trainer, having taught program evaluation courses at UMass Boston and facilitated numerous organizational developmental trainings for community-based organizations throughout the US. An alum of the CDC's Institute for HIV Prevention, Ms. Tula holds a degree in community planning with a concentration in nonprofit management from UMass and a master's certificate in nonprofit leadership and management from Boston University. Ms. Tula has been nominated by the Massachusetts Department of Public Health for the prestigious Robert Wood Johnson Community Health Leadership Award. I'm also delighted to introduce Ms. Maia Szalavitz. Maia Szalavitz is the author of Undoing Drugs, The Untold Story of Harm Reduction and the Future of Addiction. If you haven't read it yet, you should order it. It's amazing. This is the first history of the harm reduction movement and its success in moving America towards more compassionate and effective approaches to addiction. Her previous book, Unbroken Brain, A Revolutionary New Way of Understanding Addiction, was first published in 2016 and was a New York Times bestseller. It received the 2018 Media Award from the National Institute on Drug. I can't bring myself to say the word. We'll call it drug addiction. Her earlier book, Help at Any Cost, How the Troubled Teen Industry Cons Parents and Hurts Kids, was the first to expose the damage caused by the quote unquote tough love business that dominates youth treatment and helped spur congressional hearings on the matter. She's also co-authored and authored 6 other books, including the classic on child trauma, The Boy Who Was Raised as a Dog, with Bruce Perry. In addition, she has written essays and features for numerous publications, from High Times to the New York Times. So with that, I'm going to turn it over to these two amazing experts and visionaries in harm reduction, and I can't wait to hear their talks. Thank you all again for joining us.
Thanks so much for having us. So I believe I am going first. Okay, great. And can we have, yes, excellent. Thank you so much. And thanks so much for having me to speak here. I'm really honored and really delighted to be here as well. So I want to talk today about the history of harm reduction, what it is, where it comes from, and why it matters, all of which are the subjects of my new book, Undoing Drugs. I'll start with my personal experience. Next slide, please. When I visited my friend Dave on New York's Lower East Side sometime in 1986, all I wanted was heroin. I knew he could score for both of us, and so I gave him money and sat down to wait in his living room. With me was a woman I hadn't met previously. I learned that she was visiting from San Francisco and that the plan was for this to be his last drug binge before rehab. Next, please. But then I learned some information that would both infuriate me and save my life. Basically, I was told that I was at risk for AIDS, which I hadn't known despite reading 2 newspapers a day and regularly watching TV news. Most of the coverage then focused on gay men. If drug users were mentioned at all, it was kind of as an afterthought. Thankfully, however, Dave's girlfriend told me how to protect myself. Next slide, please. First, if at all possible, I should avoid needle sharing, she said. But if I couldn't, I should thoroughly rinse my syringe twice with water, twice with bleach, and just make it as clean as possible. I didn't know at the time, but I was being taught harm reduction. And this here is a poster from San Francisco where outreach to drug users actually even had its own superhero with late night TV commercials. Because of her work in San Francisco, Dave's girlfriend knew that I wouldn't instantly stop injecting just because I learned about AIDS. She knew that that wasn't how addiction works. Next, please. Critically, though, she also had information that could help me even if I did continue to take drugs. And she knew that if she taught me how to reduce my HIV risk and provided a practical way to do so, I would take her advice. And indeed, from that moment forward, I was as compulsive about using bleach as I was about using needles, which, mind you, was pretty compulsive, especially when I was injecting cocaine. This meant that when I recognized that I needed to stop, I was not HIV positive, even though half of all New Yorkers who shot drugs at the time, including my friend, were already infected. Next, please. But I was still furious that I hadn't known I was at risk due to injecting drugs, furious that there was a simple way to protect myself that officials not only didn't tell me about, but actually tried to keep other people from telling me about it because they thought that would send the wrong message in the war on drugs. I began trying to help, at first in small ways like writing graffiti in bathrooms where I knew people shot up, and then in larger ways by becoming a journalist and trying to get the information out there as best I could. Next, please. Before I get into the broader history, I want to talk a little bit about what harm reduction is. There are many definitions, but to me, it's basically any policy that focuses first on stopping people from getting hurt, not stopping them from getting high. In areas outside drugs, like say COVID, it's about helping people reduce risks rather than assuming that everyone will always avoid risky behavior. The idea that harm is what matters most is of course ancient. The Hippocratic Oath famously includes first, do no harm, since probably for most of medical history, the danger of being harmed by treatment was at least as great as the danger of being harmed by whatever the problem was. Next, please. Before I get into anyway, in the drugs world, harm reduction originates in the AIDS crisis, starting with syringe exchange. And it originates in a collaboration between people who use drugs and public health officials who recognize that without understanding and centering those who are most affected, they would not be able to find effective ways to change behavior. The first needle exchange program was founded by Nico Adriaens, who's shown here, a Dutchman who also started the world's first drug user union, or junkiebund, as he called them in Dutch. He chose deliberately to use that charged word junkie in order to fight stigma. Next, please. Anyway, Adriaens himself injected drugs. In 1981, in Rotterdam, where he lived, there was an outbreak of hepatitis B. This was before AIDS was even discovered, or at least the HIV virus. Hepatitis B usually isn't deadly, but that year it had already killed 6 people. And because of his own experience, Adriaens wasn't swayed by misinformation about how drug users like sharing needles or won't bother to use clean ones. He knew that bloodborne disease could be prevented by giving people clean needles. And so that's what he and his group did, with support from public health officials and drug policy reformers. Next, please. They also collected used needles to get them off the street, and so needle exchange was born. And when HIV was found among IV drug users not long afterwards, Rotterdam already had a needle exchange, which had then greatly expanded. Amsterdam and other cities in the Netherlands soon rapidly started their own. And likely because of the junkiebund's activism and its head start, Rotterdam had proportionally fewer cases of HIV among drug users than Amsterdam did. Next, please. Meanwhile, in the 1980s in the UK, a catastrophe was underway in Edinburgh, Scotland. Economic decline, loss of factory jobs, a supply of heroin from Afghanistan and Iran had led to a huge rise in drug injecting among teens and young adults. In response, the city cracked down on needles, squeezing suppliers and arresting users. Making matters worse, they decided that the only way to treat addiction was complete abstinence, so they closed the city's only methadone program. Next, please. The result was that when a doctor tried out a new test that could identify HIV, half of his patients who were IV drug users came up positive. Now, this caused panic across the UK, and it was enough to make the Scottish government start prioritizing HIV prevention over the drug war, as you can see here. Now, it also galvanized people in Liverpool, which had many of the same ingredients as Edinburgh in terms of job loss and widespread heroin injecting. But so far, it had no HIV. Next, please. Enter Alan Parry, who's on the right here, Peter McDermott on the left. And we have Russell Newcomb, Alan and Lynn Matthews, and Dr. John Marks, and many more, but these are some of the key players. Together, they would create what first was known as the Mersey model for dealing with drug and HIV risks. It would include multiple strategies for improving the health of people who use drugs, from needle exchange to education on wound care to providing pharmaceutical heroin and cocaine themselves to have a safe supply. This was doable because the UK had never outlawed medical use of these substances to treat addiction, unlike the US. And so in 1987, Russell Newcomb, a psychologist and also a drug user himself, came up with a memorable term to encompass all of these approaches. He called it harm reduction. This is the first publication where he named it. It's basically an addictions field trade journal in the UK. And as you can see, copy editing was not exactly their strong point. Together, these academics and drug users developed the idea that public health needs to meet people where they are to minimize harm. In order to do this, people with lived experience must be full partners with public health officials, not passive recipients. And critically, they recognize that compassion, not judgment and shame, is what helps people's lives become happier and healthier, regardless of their level of drug use. Next, please. In fact, they found that while doing their work, being kind to people helps them be kinder to themselves and leads to healthier behavior, not increased drug use. Indeed, compassionate access to safer drugs and clean needles enables life and does not lengthen addiction. And this has been shown in studies over and over and over by now. Next, please. Thanks to harm reduction, Liverpool would never see the HIV rates that decimated users in Edinburgh and New York, nor would other cities in the UK, because the Thatcher government made harm reduction official policy in 1988 based on the report quoted here. In 1988, of course, the United States banned federal funding for needle exchange, just to show the contrast there. Next, please. Not surprisingly, harm reductionists wanted to share their success with others. To spread the word, they founded a journal, now the International Journal on Drug Policy, and they began holding conferences to discuss and promote the idea. Because it was pragmatic and it seemed like common sense to public health people, it began to catch on throughout Europe, where drug policy was not as politicized or as racist as it is here. Next, please. It also captured the attention of Americans, who would bring harm reduction into the fight against AIDS here. The first of these is a social worker and drug user named Edith Springer. She was introduced to Liverpool's Alan Parry at her office. And when she met him, she just was overwhelmed and completely changed her perspective. In 1988, she was also working with a group called ADAPT, which was led by a woman named Yolanda Serrano. Serrano and Springer were both tired of losing people that they loved to AIDS. They both fought to free drug users from Rikers Island, where there was an absolutely horrific AIDS ward that they had to actually stir up a hunger strike in order to get the conditions to approve. But they also really most tried to get people out of there, of course. Next, please. The two women also led ADAPT into the community, going into shooting galleries with bleach to teach people about how to protect themselves. Serrano got the label, the Avon Lady of AIDS, the Avon Lady of AIDS prevention, rather, while Springer soon became the goddess of harm reduction. And crucially, in late 1989 or early 1990, Serrano would spur the AIDS activist group ACT UP to start illegal needle exchanges after the legal pilot program was shut down by New York City's mayor. Next, please. John Parker, whom the New York Times also gave a very cute name, the Johnny Appleseed of Needles, had begun deliberately getting arrested in cities up and down the East Coast in order to challenge the laws that made syringe exchange illegal. And he too joined forces with ACT UP in early 1990 to try to do the same in New York City. In New York, Parker and these ACT UP members, we can see on the far left corner, Dan Williams, right, mostly in the center is Richard Elovich. Next to him is Greg Bordowitz, and I'm pretty sure that that is Catherine Otter on the side, and I do not know the name of anyone else. Anyway, they became the Needle 8, and they won their case in New York City by arguing that syringe exchange is necessary to protect public health. Edith Springer, meanwhile, went on to train thousands of people in how to do harm reduction, including nearly all of the movement's first leaders. Next slide, please. Springer was a member of the Foundational Harm Reduction Working Group, which eventually became the National Harm Reduction Coalition, which Monique now leads. Another key member of that group was a woman named Imani Woods. She was initially, according to both Imani and Edith, the most resistant student Springer ever encountered when she was trying to teach harm reduction. But then she became this completely converted, absolutely intense ambassador of harm reduction, especially to the Black community. Springer also trained a Chicago man named Dan Bigg, who is seen below her in this picture here. Next, please. He recognized that people on the street, not just doctors or police or other officials, should have access to naloxone, which, as I'm sure you all know, is a safe and effective antidote to opioid overdose. Dan spread that message and the drug itself across the country. And without him, naloxone might still be only available in medical settings. So his work has saved at least hundreds of thousands of lives. Next, please. Another social worker and drug user trained by Edith Springer was Keith Kyler. He was one of the founders of Housing Works, which is one of the world's first Housing First programs. And Housing First is the idea, basically it takes the idea of harm reduction into housing. So basically it sees everybody deserves a home, and expecting people to stop using drugs while homeless is both senseless and cruel. Next, please. I don't have time to get into the thousands of other folks, but there are, who made important contributions. But I wanted to mention at least a few because these ideas offer the only effective way out of our current overdose crisis. One of the most important ideas in harm reduction is that risks must be understood in context. You can't, for example, stop addiction by simply cutting off access to medical opioids, which unfortunately is what we're doing right now on a massive scale. As shown here, since 2011, the medical opioid supply has declined by about 60%. And the hope was to reduce overdose death. As you can see by that red line and probably your own experience, that is not what happened. Next, please. Oops, are we? Okay, so we need to be a couple more. Yeah, okay, this is where we should be. Thank you. Sorry about that. Okay, but indeed, when we cut the supply, the fatalities actually more than doubled. And more people died from overdose when prescribing was falling than died when it was rising. Next, please. Harm reductionists had predicted that this approach would backfire. For one, it drives addicted people to street drugs, not to recovery. And secondly, because smaller drugs are easier to smuggle, crackdowns push dealers towards more potent and therefore more risky products. Our policy also increases disability among people in pain because cutting off opioids doesn't cure either pain or addiction. Next, please. In contrast, harm reduction recognizes that people use drugs for reasons and that cutting the supply doesn't cut this pain. Consequently, harm reduction threatens both the ideology and the tactics of the drug war. Because if harm reduction is the goal, the harm associated with drug policy counts against it in a way that it doesn't when the measure of success is the amount of drugs seized and the number of arrests. And if harm reduction is needed as an alternative to the drug war, well, the drug war must not be working so well because successful policies should by definition prevent harm or reduce harm. Next, please. Harm reduction also threatens the drug war because it is evidence-based, whereas ideas like hitting bottom and tough love and enabling do not stand up to empirical investigation. Indeed, as this now infamous New York Times op-ed shows, the basis of our war on some drugs and not others is racism and not science. Next, please. So let's look at the evidence in favor of harm reduction. So we'll start with needle exchange. All of the major reviews show that it cuts the spread of HIV without increasing drug use. The CDC found that needle exchange participants are 5 times more likely to get treatment compared to people who do not participate. New York State is a great example of how well it works in conjunction with expanding methadone and expanding access to needles at pharmacies. We drove HIV prevalence among IV drug users from over 50% to now under 3%. And needle exchange is also associated with reductions in HIV, hepatitis C, needle litter, and injecting. And I have footnotes for these for those who are interested, just let me know. Next, please. Okay, so what about prescribing buprenorphine, methadone, and heroin? So the World Health Organization lists buprenorphine and methadone as essential medicines for addiction. They are associated with a 50% reduction in mortality when people stay on these medications, and that is not true of any other treatment that we have. They also are linked with a similar reduction in all-cause mortality, including cancer and heart disease, which sounds strange, but is often due to the fact that if people are in treatment, they are also in touch with other healthcare. Now, when these other opioid agonist medications fail, heroin itself has been shown to work. And all of them reduce drug use, crime, HIV, and hepatitis. Next, please. What about naloxone? So one big study in Massachusetts looked at areas that either implemented it intensely, which means getting a lot of naloxone out there and training a lot of people to use it. And they compared them to neighborhoods where they didn't do any of that. And they found a 50% reduction in overdose deaths. There's a systematic review that supports their efficacy. And common sense just suggests that if you have the antidote to something, it's more likely to save lives than if you don't have the antidote. Next, please. Safe injection facilities, also a systematic review in favor of them. There's a study in Vancouver that found that near Insight, their main safe injection spot, the overdose deaths in the immediate neighborhood are lower than those further away. And for safe injection sites to work, they really have to be very close to the people who use them, because people are not going to like drive to get to a safe injection site. Anyway, it's also associated with reductions in HIV, hepatitis, increased admission to treatment, less needle litter, and less public injecting. Next, please. In contrast, there's no evidence for the idea that tough laws and harsh confrontational treatment aimed at making people hit bottom are effective. In fact, research shows that confrontation worsens addiction outcomes, and jail increases the risk of HIV and overdose death. And the number of drug arrests is not at all associated with reduced drug deaths or less drug use, as it should be if it was working to prevent addiction or get people into recovery. Next, please. I will admit I am partial to harm reduction, and yes, I had to have a cat slide because I believe that it saved my life. And when I set out to write this history, I wanted to thank the woman who first taught me to use bleach, but I knew nothing other than that she was from San Francisco and she was female and she knew my friend Dave. But I am a reporter, so I figured I could at least try to find her. Next, please. And indeed, after probably 30 phone calls and emails, I learned that her name is Maureen Gammon. In an odd coincidence, she's from Liverpool, even though she didn't know the early harm reductionists because she'd already immigrated here by the time they started their work. But this is her on the right doing outreach back in the day. Next, please. And when we finally spoke, we were both overwhelmed. I was, of course, glad to have found her and glad to let her know how much of a difference she'd made for me. And for her, that information mattered too. It's often during your day-to-day life really hard to see that you actually are having an impact and you actually are changing things. Next, please. As I noted in the book, it reminded me of a parable of a child who finds hundreds of starfish stranded on a beach and begins throwing them back into the sea one by one. An adult asked, "Why are you bothering? You can't possibly save them all." And she said, "Well, it matters to this one," as she throws another one home. And that's the beauty of harm reduction right there, seeing value in every life. Next, please. And when we practice it as a philosophy, it's transformative because we all have gifts to give and we all contribute to the world and we all also do harm as well, even when we're trying not to. So harm reduction is a gift from people who use drugs to everyone. It says you matter whether you take drugs or not. You deserve to live whether you get high or not. You can help, you contribute, you can reduce harm, again, whether you get high or not. And those are the things we kind of really all want: to matter, to make a difference, to care, to be cared for. Next, please. We don't change overnight generally, and we all take risks that do harm. But if we work together, we can minimize that and empower each other to do better. So again, I send my appreciation to Maureen Gammon and hope I can finally see her as this pandemic winds down. And I thank you all for giving me your time and attention. Thanks so much.
Next up, we have Monique.
Thanks, Maya. That was amazing. I'm so glad that you found her.
Thank you.
I cannot wait to read Undoing Drugs. So hello, everyone, and greetings from North San Diego County, California, where the Pala are the original custodians of this land. I want to say thank you to Sarah and Elizabeth and everyone else who helped organize the event and gave me the opportunity to speak with y'all today. I am not a native New Englander, but I spent almost 20 years there, right in Boston. I have a serious love for Massachusetts because 25 years ago, I found harm reduction and found my purpose. Next slide, please. So I joined the National Harm Reduction Coalition as the executive director about 5 years ago. And as I mentioned, I've been a harm reductionist since 1997, when I worked at this tiny syringe service program in Western Massachusetts. And Massachusetts, as y'all may know, is one of the first states in the country to pass legislation for limited support for syringe service programs. My organization was, as Maya mentioned, founded in 1994 in response to the unabated AIDS epidemic among people who inject drugs. Nobody else was focusing on people who inject drugs apart from this amazing harm reduction working group. So the National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policies. Now, this is our North Star statement, and we created it 3 years ago because our shifting responses to drugs and the people who use them have always been intertwined with race. Now, an extraordinary amount of attention recently has been given to substance use disorders and overdose and suicide and other problems that are faced by a class of white folks whose worsening health and discouraged outlook has fueled right-wing populist rhetoric. This attention was accompanied by greater recognition that substance use disorders are primarily a health challenge to be prevented or treated, which is great progress. However, the dominant frame when substance use disorders was perceived as mainly an issue in Black communities wasn't that it was a health challenge to be prevented or treated, but a crime to be punished. A deeper and broader point is also sometimes overlooked: structural racism. It's not only led to policies and practices that repress Black Americans and deny them freedom, health, and opportunity, but it also generated these deaths of despair that we hear about among white communities and has prevented constructive solutions to pressing problems for the whole country. So transcending the barriers of whiteness is essential to improving the health and well-being of the 100 million Americans of all races who live in economic insecurity. It's fundamental to creating an economy that's less extractive and more sustainable. White identity remains the implicit standard of normalcy and entitlement to the rewards of society. And this leads to the acceptance of marginalization, othering, and too often, dehumanization of those who aren't white. Next slide, please. So why does harm reduction matter? There are dozens, if not hundreds, of studies that show that the drug war has failed us. Narcotic trafficking is rampant. People who use drugs face daily stigma, and jails and prisons across the US are full of people who committed nonviolent drug offenses. So it's clear to me, and I'm sure it's clear to most of you, that we need another approach. Over the last 5 decades, American taxpayers have dished out about $1 trillion on the war on drugs, and what all that money has helped produce, aside from skyrocketing drug addiction, is the world's highest incarceration rate. According to recent data from the Federal Bureau of Inmate Statistics, nearly half of all inmates are there serving time for drug offenses. So racial disparities in drug arrests also reflect a history of complex political, criminal justice, and socioeconomic dynamics that are individually and cumulatively affected by racial concerns and tension. So reducing disparities is imperative, but that's not going to be accomplished by simply increasing the rate of white drug arrests. It's not what I'm saying. A fresh and evidence-based rethinking of the drug war paradigm is critical, because if not, we're at risk of repeating history. We know that harm reduction alone cannot heal the harms of the drug war without bridging the divides that it's caused. We live in a world where the presumption of guilt and criminality follow nearly every Black and brown person every day. The stigma that follows sex workers and drug users and people who are disabled, people who are queer or trans or gender nonconforming. All of these are the reasons behind our North Star statement. It's the importance of remembering who historically has borne the burden of oppressive racialized drug policies, and we're loudly proclaiming that we won't forget. Next slide, please. So I was on a call recently with a number of executive directors of harm reduction programs around the country. We started this group right after COVID just to kind of bring people together to talk about what was happening in their regions, in their programs, and also for a little bit of mutual aid. And one of my colleagues said something that was particularly profound. She said, you know, certain service programs can help keep people alive just long enough for them to get COVID. I was stunned. In many regions of the US, drug-related stigma, lack of political will, zero funding is literally killing us. And during one of the defining crises of our time, there are still far too many states that still don't have policies that support harm reduction strategies like syringe service programs and naloxone distribution or drug testing. So again, Massachusetts was one of the first states in the country that passed legislation, but for the first 20 years or so, only 4 legal programs were in operation, despite that early legislative support. So it's not enough to change policy. Policy is only as good as the people who practice those policies. It's the quality of our interactions that has to change as well. Next slide. So building on Maia's research about the history of harm reduction, I wanted to just quickly provide a little additional context about how harm reduction has evolved, which informs where we're headed. So the origins of harm reduction actually extend far beyond what we've come to think of as traditional harm reduction. We could start with when the drug war actually began, which wasn't in the 1970s, but actually the 1870s. So the first anti-opium laws in the 1870s were directed at Chinese immigrants. But in the US in the 60s and the 70s, the Black Panthers and the Young Lords brought this new message of self-determination to the post-civil rights environment. So the Black Panther Manifesto, which was updated in 1972 by Elaine Brown, included an explicit demand for free healthcare for all Black and oppressed people. The Young Lords had 7 demands for Lincoln Hospital when they infamously took it over in 72. And included in those demands are unfettered access to nutrition, treatment for drug addiction, and child and elder preventative care programs. So the Panthers and the Lords' bold vision and long-term strategies sought to destroy a 500-year hegemonic legacy of white patriarchy. They knew that the likelihood of their success was questionable, but they persisted because inaction led to death. In the 70s, there was also a group of Black feminists who came together to co-create the Combahee River Collective Statement, which is known as the birth of Black feminist theory. And their body of work was the basis of the thought leaders like Kimberly Crenshaw, a Black woman who coined the term intersectional. So members of the collective knew that the major source of difficulty in their political work isn't that they were just trying to fight oppression on one front or even 2 fronts, but instead to address a whole range of oppressions, intersections. They knew, because they lived it every day, that Black women don't have queer Black women don't have racial, sexual, heterosexual, or class privilege to rely on. And we don't even have minimal access to resources and power that the dominant culture possess. So as abruptly as those stories seem to end, the legacy of the Panthers and the Lords, along with the Combahee River Collective and popular education pioneers like Paulo Freire, shaped the future of social and public health activism, including harm reduction. So we can't talk about the evolution of harm reduction without naming that the fact naming the fact that the entire movement in the US was born in a country entirely based in white supremacy. So even harm reduction has its roots in institutional racism. And drug user and sex worker liberation can't happen until all Black and brown people are free. You can skip the next slide and go to the one after. Thank you. So by the 2010s, the harm reduction programs were in nearly every state of the country in varying degrees. And Maia's talked about this, right? Many harm reductionists attribute the steady decline of HIV transmission among people who inject drugs to this modest scaling up of needle exchange programs, now called syringe service programs. But there were fissures that were forming in the broader harm reduction community. So for example, during the 2010 National Harm Reduction Conference, sex worker advocates called out the community in general for lack of consistent support, something that persists today and needs to be addressed. By 2012, we started to see the third wave of opioid-related deaths, which was spurred by illicit fentanyl being laced into heroin and illicitly manufactured opioid pills. The Buyers Club that year was formed in an effort to get naloxone directly into the hands of people who use drugs. And this was led by Dan Bigg, who Maia mentioned earlier. So they negotiated with Pfizer, which was then the major manufacturer of naloxone, to allow expanded access to affordable products for harm reduction programs. And today, the Buyers Club is comprised of well over 100 programs in the US that distribute generic injectable naloxone directly to people who use drugs. Dan passed away on August 21st, 2018, but the work of the Buyers Club continues in his name and memory. How many people remember what happened in Scott County, Indiana in 2015? More than 200 people who use drugs were diagnosed with HIV and Hep C in and around Austin, Indiana. And the route of transmission was injection drug use, either their own or by having sex with somebody who injects. So in Scott County, like in many other regions of the country, opioid prescription, over-prescription of opioids was at the root of people's addiction. And once prescription drug monitoring programs were launched, eventually people couldn't afford to buy Opana or whatever opioid they were using or get their doctors to prescribe it. So they didn't stop using because interdiction doesn't work. They turned to heroin because it was cheaper and easier to get. They shared needles because they didn't have access to clean ones. There was at least one positive outcome that grew out of Scott County, and that is this rising awareness about opioid addiction that has caused people to rethink the way they see people with substance use disorders. So that's in part why we've seen this shift away from penalizing people who use drugs to more of a public health approach, kinder, gentler approach. So the opioid crisis and the ensuing overdose epidemic drew a lot of attention to harm reduction, and people everywhere were scrambling, right, to figure out how to address rampant addiction and overdoses caused by opioids. And a clear example of this was in 2018 in New Orleans, where my organization hosted the world's largest harm reduction conference, where more than 2,000 people were in attendance. And also that same year, Surgeon General Jerome Adams, who bore witness to the calamity in Scott County where he was the chief public health officer in 2015, he actually endorsed naloxone. And we also started to see this support for medications for opioid use disorder increase. Next slide. But despite growing support, harm reduction couldn't stem the unrelenting tide of overdoses. There have already been these 3 waves of overdose epidemics in '99, beginning right here or right there in New England with prescription opioids. Then again in 2006 as people transitioned from pills to heroin, and then again in 2012 when fentanyl hit the drug supply. And as a result, we're in the midst of the longest sustained decline in life expectancy for Americans since World War II, suicide and fatal overdoses, and now COVID are behind it. There was a recent AMA issue brief that cited more than 400 articles written about COVID and overdose between January 2020 and just last month of August 2021. And in the issue brief, they highlight reports that showed increases in drug overdose mortality and concerns related to access to evidence-based care for substance use disorders. Nearly dwarfed by the COVID pandemic, the overdose epidemic is still one of the defining crises of our time. Last year, there were nearly 93,000 overdoses, drug overdoses, many attributed to complications from COVID. That number far surpassed the death rate of at the height of HIV in this country. It's the highest number of overdose deaths ever recorded. Isolation has always played a risk in drug overdose, and over the past 18 months of COVID-forced isolation and social distancing, we're seeing more and more and more overdoses. Now, harm reduction is tried to discourage people from using alone, because if no one's around, then the likelihood of reversal is pretty minimal. Additionally, COVID forced the curtailing of in-person treatment and group counseling, so there's far less emotional support, which we know is vital to successful substance use disorder treatment protocols. Despite this, syringe service programs during COVID have been making sure that participants still have sufficient access to injection equipment and naloxone. They figured out how to distribute supplies in ways that minimize close contact. And this was the time that I heard from my colleague running this exchange in Indiana that she was barely able to keep up with the demand for services, barely able to help keep people alive long enough to get COVID. So in March of this year, the federal government approved the largest ever appropriation for harm reduction at $30 million, and an even larger appropriation is on deck that would also remove the long-standing ban of the use of federal dollars to buy needles. It should be a time of hope in the harm reduction world after decades of being underfunded and dismissed by the federal government. Thank you, Elizabeth. It should be a time of hope, but instead, organizations around the country are scrambling to provide their communities with life-saving medications central to overdose prevention, naloxone. There was a recent Filter Mag article that reported, as naloxone grows more scarce, more people are reverting back to strategies that we used over a decade ago. So posting resources on social media about what to do in an overdose when there's no naloxone. And what happened? In late April, Pfizer quietly communicated that their naloxone supply would be interrupted, toppling what was already a precarious distribution network. And insiders confirmed that the shortage has devastated community-based naloxone distribution like the Buyers Club. And just last month, Pfizer listed the availability of its injectable naloxone formulation as depleted. So these supply disruptions are causing the worst naloxone shortage in the country since 2012, when overdose levels were less than half of what they are now. Next slide. So it's bleak. We have come a long way over the last 28 years. We've seen support grow for harm reduction in ways that we've hardly dreamed of. The $30 million that I just spoke about. SAMHSA is finally opening itself to integrating harm reduction. After nearly 30 years, the ban on the use of federal funds to purchase needles is finally being lifted. We're seeing syringe service programs, naloxone distribution programs, and MOUD expand. We've seen drug decrim and reform becoming a reality through legalized marijuana, elimination of paraphernalia laws, and scaling up of Good Sam laws. Next slide, please. Harm reduction is about shifting power and resources to people most harmed by structural violence. We can't have that discussion, though, without naming once again the stranglehold that the criminal justice has on us, which quite literally played out on George Floyd's neck. The war on drugs is inextricably linked to the struggle for racial justice in the US. This past June was the 50-year mark when Richard Nixon officially launched the war on drugs, in part to win more white voters in the South. And he knew that by linking drug use to civil rights protests in Black communities, that he could appeal to white voters who were opposed to racial oppression. And that's not a conspiracy theory. It was corroborated in a 1994 interview with John Ehrlichman. So the racial uprising is a wake-up call for America. It's a reminder of all of the ways that systemic racism impact every aspect of Black life, from police violence to COVID pandemic to substance use disorders to the housing crisis. There is no, as Audre Lorde says, there's no single issue. There's no such thing as a single issue struggle because we don't live single issue lives. And I'll just stop there so we have time for questions.
Thank you so much, Maya and Monique. I want to open the floor for questions for the last 12 minutes that we have, so people can feel free to comment in the chat or just unmute yourself and ask a question as well, if that's easier. Mark Eisenberg has asked, please comment on the next frontiers, including safe consumption spaces and provision of a safe supply.
I could say something. I think safe consumption spaces are really important, and it'll be very interesting to see what the Biden Justice Department will do if somebody actually moves forward, and I think Rhode Island has just authorized them. So that should be interesting, and hopefully they will not be just giving lip service to harm reduction. They will actually be having a drug policy that is based on harm reduction. And so, I mean, I think we need safe consumption sites, but more importantly, we need a safe supply, because safe consumption sites are only going to be able to reach a minority of people in areas of very concentrated drug use. People are not going to like drive 10 miles to go to a safe injection site, and because of NIMBY, we're certainly not going to have a safe injection site on every corner. So I think a more scalable solution is safe supply. Now that faces its own issues because we have Supreme Court decisions going back to 1919, where they basically said it is illegal and it is not legitimate medicine to provide medications for the comfort of an addict. So while you are allowed to comfort pain patients and basically everybody else, you may not use a drug specifically to comfort. And so that basically means you cannot prescribe anything other than buprenorphine or methadone to maintain people. And it also means that we have these insanely restrictive regulations around buprenorphine and methadone. And it also leads to this horrific policing of pain patients and anybody who's seen as a person with addiction by the medical system, because if the doctors don't police this, they can lose their license. And since they're being asked to police something that isn't scientifically sensible or moral or humane, it just ends up being a giant mess for both people in pain and people with addiction. So working on safe supply is critical. The other big thing is decriminalization of possession of all drugs. And I've said this before, but nobody can give me a good argument for criminalization of possession other than, well, we need to send a message. And given that we're all around saying, oh, we don't want to stigmatize drugs, we don't want to stigmatize drug users, that's what stigma is, sending a message. That's what the message is. The message is stigma. So since we know it doesn't work to do anything, and the message is not being received, or we think that message is a bad message to send, which I certainly do, then you cannot make a good argument for sustaining criminalization. And I think a lot of people have been awakened to the racist nature of these laws and are feeling like they want to rethink it. And so Oregon has just decriminalized. I know other states and localities are pushing for it. I think this is actually winnable, provided we don't have some giant, massive backlash. Because again, they cannot provide a coherent, sensible argument for what they are doing. And it's hugely, hugely expensive. And it's taking away money from things that we know do work. And since like we see this as white, we are more inclined to have compassionate goals, which sucks, but at least we could use it in our favor in this situation.
Someone asked, is there a database of all harm reduction programs across the US?
So on our website, you can find links to maps of both syringe service programs and naloxone distribution programs. So www.harmreduction.org.
That's great. Thank you, Monique. There's a question about harm reduction in school, substance use in school-based settings. It has increased exponentially in the past few years and has racialized drug policies and punitive policies that disproportionately impact students of color who are far more likely to be disciplined for any substance use offenses. Can you comment on this?
Well, I'm not sure what the question is. Like, should we not be talking about substance use and the racialized nature of drug policy in this country in schools? Is that what the question is?
I think it's leading more towards the sort of drug-free community and drug-free school policies that actually criminalize and punish Black and Latinx children in a way that white kids are not subjected to. So actually perpetuating the harms of sort of the war on drugs, but at the school level.
Yeah. So I don't know a ton about what's happening in the education system. And I think, just thinking about like coherent policies that you were talking about, Maya, we know that coherence is not necessarily what propels people into public office. What I do know is that harm reduction in some ways is a Band-Aid approach to addiction and some of the other ills that society is facing. It's all we can do to, as the ED of that harm reduction program spoke about, keep people alive until the next thing comes up, right? And so, yeah, we absolutely need upstream approaches. But without confronting institutionalized racism across every system and structure in this country, the best intended policies are not going to work and will end up having the likelihood of them having like the reverse impact is pretty likely, right? So I don't know that that answers the question. I think that I'm in agreement with the statement.
A question for Monique. What role does abolition play in addressing societal harms associated with drug addiction and drug prohibition?
I think it plays a huge role, whether we're talking about abolition, which is the complete dismantling of the prison industrial complex and all of the policies that prop up that institution or those institutions. Whether we're talking about abolition or reform, we have to start somewhere. And I think abolition is a topic that's really scary for people, right? I hear a lot of times, when we talk about abolition, well, what about the race? What about the rapist? What about the pedophiles? I don't have an answer. What I do know is that the system that we have right now is not working. And I wouldn't shy away from having a conversation about, and I have shied away from having a conversation about abolition because I don't have the answers. But we've passed that point. I think that our conference in Puerto Rico in 2022, which I hope that you all get to attend, it's going to be in San Juan, if I can just tempt you a little bit. I think a huge focus of our conference is going to be focused on abolition and reform.
And I mean, I do think that even though people are kind of fed up with incremental approaches, that we can move towards that by doing the easy stuff first. like getting, like decriminalization. That doesn't mean that we don't have a ton of other hard work beyond that. But I think what has happened, and I think this is an important thing for the marijuana movement, is just that, like, when you see that the sky doesn't fall and all those things the prohibitionists said would happen don't actually happen, people start taking your other arguments more seriously. And they start to think, well, maybe we could do this because the other things, that the other catastrophes didn't unfold, and they're still saying these catastrophes are going to unfold from this. So, but yeah, I think it's such an important conversation, and I think it's also one of those instances in activism where you need the people on the really far out corners to bring the people along. Where we need both ends of that so that it can move, if that makes any sense.
Yeah, and if we're abolishing prisons and jails, where are people going to go? We already have a housing crisis, right? I saw a video recently of Methadone Mile, and I used to live right outside of Andrews Square, and would walk home from BMC. It's unrecognizable to me. I can't believe what I'm seeing. I thought I was looking at streets in Los Angeles where people who are houseless are lining the streets in living in tents. So I couldn't believe that it was Boston. But my point is, abolition, it's not just about dismantling prisons and jails, right? What happens to people? Where do they go? How are we caring for people once they leave those systems?
We have like 1 more minute left, so I'll just put in this last question. Can you comment on success of progressive policies in Europe, for example, Portugal on decriminalized drug use, or other countries?
Well, as far as I know, and I actually did get to visit Portugal, it does remarkably well. There is no evidence that criminalization helps in any way. So when you take that money away and you put it into treatment and housing and support for people, not surprisingly, people do better. And there have definitely been, reductions in HIV, reductions in overdose, no higher drug use than other areas of Europe that are similar. So in other words, drug use went up all over Europe, but it wasn't especially worse in Portugal. And it's, it's just common sense. Whenever we've looked at the empirical results of being kind and supportive and providing people what they need, it actually helps. And I mean, we don't want to be publishing in the journal of the journal of obvious results, but we should, because we need people to come along because they don't think that that this is obvious, obviously, because we have so many cruel policies. And obviously some of them are maintained under a fiction of being supposed to do one thing, like fight drugs, while they're actually doing another thing, which is oppress people. But I think that, all of the data that I've seen, the only disaster of drug policy in Europe that I ever heard of was Needle Park in Zurich, Switzerland. And I'll keep this brief. Basically, during the height of the HIV epidemic, they decided, okay, we're just going to basically legalize dealing and using in this one park so that we can bring HIV services in. And that was indeed a disaster and attracted drug users and other folks from all over Europe. And so then they didn't say, okay, well, this obviously won't work. Like, we need to just go back to harsh prohibition. They said, okay, let's provide heroin medically, and let's use a medical approach, not a criminal approach. And then the prohibitionists don't talk about this part. It actually worked quite well.
A huge, huge thank you to Maia and Monique. I know everyone probably has to hop off for right past 1 o'clock, but we're so grateful to have both of you with us, and to everyone who joined today, and hope that you can check out our MGH Recovery Month website for the additional events throughout the month in case you're interested in joining.
Thank you.
Thank you, everyone.
Thank you, everyone.
Bye, Monique.